Hey, I'm Bob Anderson here at Titletown Orthopedics, and I do foot and ankle disorders, and I specialize or subspecialize in sports foot and ankle. Today I thought we'd just spend a couple minutes talking about acute Achilles tendon ruptures. So this is basically an injury that we see throughout the year, more commonly when the warmer months are with us, people out basically playing tennis and but we'll see it during the winter months too with basketball in particular. We used to say acute Achilles tendon ruptures occurred more between ages 25 and 45, but now we're seeing them even younger people with their all year round sport activity, single sport specialty, where they tend to get the Achilles tendon worn down and then at risk for rupture. And we're also seeing it more in the older population, the 60-year-olds, even 70-year-olds playing pickleball. People are just basically staying more active into later years of their life and thus more susceptible to the Achilles tendon rupture. The question then is, well, what happens when you get Achilles tendon rupture? Well, the problem is when you rupture your Achilles tendon, it's like the toy, the slinky, where it pulls apart from one another due to the strong muscle contraction in the calf itself. And when you get a big gap of the Achilles tendon, typically we'll want to pull that gap back together to restore the proper tension of the Achilles tendon to allow people to get back to their normal activity level in the months to follow. However, surgery. We try to minimize complications like infection and wound problems, and unfortunately open Achilles tendon surgeries are more prone to those complications. For that reason, over the last 10 years or so, we've basically perfected the mini open or minimally invasive Achilles tendon repair. And this is where you can minimize the risks of surgery by minimizing the amount of incision that we utilize to bring the two ends back together. So let me just demonstrate. We got a wonderful subject here that's going to just demonstrate some of the things we look for when we do an evaluation of acute Achilles tendon rupture. So somebody will come in and the typical story will be, I was playing basketball, I was out in the field across the street here at Titletown practice field. I was playing tennis and I felt like somebody hit me in the back of the calf with a ball. I turned around and nobody was there was no ball there. And that's the typical scenario. Somebody says, I just got hit in the back of the calf or I got grabbed back there. They may be able to walk and limp off the playing field, but yet they notice that there's just not a good push-off strength. So when they come to the office, we want to ask them, were you having any Achilles tendon problems beforehand? Most of them will say no, and then we'll get them into a prone position on the table and take a look. So we'll ask Ryan to go ahead and stand and lie on his stomach. And we always want to compare one Achilles to the other. But what you first do is you want to look at just the contour of the Achilles tendon, comparing the injured one to the uninjured. Now, unfortunately for us, Ryan hasn't ruptured his Achilles tendon, but still some of the things that we look for are first the contour to make sure it does compare well to the other. Oftentimes you'll actually see swelling, you may see some bruising, ecchymosis, and as you put your finger down along the Achilles tendon, you may actually feel a defect, typically in this non-insertional area of the Achilles tendon here. And that's the first thing we look for, is just the contour, does it look like the other, and is there a palpable defect? In older people, what may have happened is the Achilles tendon can actually come off the bone itself. So you may not feel a defect here, you may feel a defect closer to the bone itself, and that would be the older population with perhaps some pre-existing insertional disease like Hagelin syndrome. The next thing we do is the Thompson test. The Thompson test, again, you're comparing one calf to the other, but as you squeeze the calf muscle, you should see the foot plantar flex. So the foot goes that way, and you want to compare it to the other. Unfortunately, in the subject we have here today, his Achilles is intact. Then the third thing we do is we do what's called the Maddle's sign, and that's where you bend the knee up 90 degrees, again with the patient prone, and you want to make sure that the tension in the foot is the same as the other. So the toes should point to the ceiling to some degree. If the injured side is more flat and sort of hanging there, and compared to the uninjured, which goes more towards the ceiling, then you know you've lost the resting tension in the Achilles tendon complex itself. Now, if you've got all three of those signs, if you've got a palpable defect and loss of Achilles contour, if you've got a positive Thompson test and a positive Maddle sign, you can stop right there. You know it's going to be a complete rupture of the Achilles tendon in that region. If you aren't sure, that's when you get an MRI. If you just aren't sure whether or not you may have an insertional rupture or if it's fully ruptured or not, then that's when you would do an MRI. And again, if you then determine, based on your clinical exam and MRI, that it is indeed complete rupture, the typical scenario in a healthy, active individual would be to go on and surgically repair it. And again, the mini open approach is our preference. It's a procedure that's done as an outpatient, takes approximately 30 minutes. We do an incision right along the back of the calf, right where the rupture is. We find the two ends. We've got a special device, a jig, that pulls the two ends together. And then we basically suture it in place with the foot down in this plantar flex position. Usually it's just 3 stitches on the skin is all that's necessary to close the incision. People then go home. There isn't not much pain associated with that minimally open procedure. Typically a couple days of analgesics or anti-inflammatory medication. We do keep people in a splint non-weight burn for 2 weeks. At the 2-week mark, we then convert them to either a boot or a cast, depending upon their preference. Then most patients are walking in a boot by 4 weeks with wedges that are gradually reduced in height. By 8 weeks, people are walking in a comfortable shoe with a heel lift. And by 12 weeks, we really initiate a more aggressive rehabilitative course. But that is the mini open approach. We find all the advantages of surgical repair without the higher risk of complications, particularly that of infection and wound healing problems. We also found that with the mini open repair, you get a little bit quicker recovery, a little easier recovery because of the minimal incision made. And what we found in our more elite athletes is it's a much quicker overall recovery time. We've gotten people back even 5 or 6 months to their sport, whereas these injuries and recovery times used to be in the 1 year time range. So again, a lot of advantages to the mini open approach, and again, good patient satisfaction and overall good long-term results.